And if you want to start recording, that would be great. Well, welcome members of the public to this, the last board before Christmas, so the December George Eliot board. Delighted that so many members of the public are able to join us again, and a very warm welcome. Just before we get going into the board, I would just like to make a few comments about the stresses and the strains which the Trust is under because of the combination of very high demand, the COVID and its new variants still affecting us, and it is causing lots of operational pressures. And I'd like to thank everyone on the front line and my executive director colleagues for all of the phenomenal work they're doing. The next 6 weeks are going to be very tough, and I'm conscious of discussions that are ongoing with social care colleagues to help speed up our flow. We have something like 40 to 50 what we call stranded patients having been with us for over 21 days who are effectively medically fit for discharge that we're waiting to allow to go home safely. So we're working strongly with social care colleagues to make that happen. But it is all very, very hot, I think would be the operational phrase. Delighted to also that this is, or not delighted, this is Stephen Coleman's last board with us. And so I'll mention that again when we come back to any other business. But I am delighted to welcome Patrick, who's going to be joining us on an interim basis as Chief Operating Officer. So welcome, Patrick.
Thank you.
We have apologies for absence from Glenn Burley, who's taking a very rare week off and very well-deserved week off. Are there any other apologies for absence? I don't believe so. So we'll move on. Any new declarations of interest from colleagues? Okay, I can't see any digital hands raised. So the last set of minutes of the meeting held on the 2nd of November, was everyone happy with the accuracy of those minutes? Please raise a digital hand if you want any adjustments. Can't see any digital hands raised, so I'll duly make those signed. Unfortunately, Daljit's just had to leave the call for the board for a little while. So in terms of action points arising, the first was quarterly updates on the Trust sustainability strategy to be scheduled, and that has been done. Thank you, Vanessa. The second was an action point for Daljit, but it's not due until apologise, that's a technical problem of mine. That's not due until next year, so we will get updated on that later. Then we have the conversion data on applicants offered a post to George Eliot versus those who subsequently accepted to be included. That's also coming back in February. Then a report on acuity and dependency reviews and outcomes, that's on the agenda. And then a future board work discussions focus on workforce planning. We did that this morning. It was a very interesting session, and thank you for Gertie for organising that. Then we have the Jenny to liaise with Optum's programme lead at system level about presenting a case study to the board regarding population health management. That's arranged for March next year. An update on capital digital allocations, that's complete. Thank you, Glenn, for doing that. An update on industrial action to be included in next month's Chief Executive report. That's been done, and we'll cover off that later. A deep dive into shared service delays and referrals to be brought back to a future board workshop. That's been deferred until February. Further update on CAFED rapid testing solutions. Where are we with that, Stephen?
Yes, I think, Russell, last time we were at board, this was just being introduced. So I think it was just for some quick feedback. So we've introduced it. It's gone actually really well. AD colleagues are really happy with it. particularly in terms of times of swab results that we're getting back, and the accuracy around them and the ability to place patients as a result. So that, I think if that's okay, we can close that off. It's going well.
Okay, great. Thank you, Stephen. Then on the board assurance framework, high-risk target dates to be revisited by the executive team to ensure we're being realistic. I'll come back to that at the beginning of next year as well. Then the format of future improvement board reports to be reviewed to ensure they're succinct and reader-friendly. Thank you, Jenny. And then finally, a latest position regarding 28-day transfer. That's reflected in this month's integrated performance report. Have I missed any action points arising? Please raise the digital hand. Okay, well, in Glenn's absence, David is kindly going to pull out the highlights of Glenn's chief executive report. So David, over to you.
Thanks, Russell. So it's quite a long report this month and covers quite a lot of ground. And Glenn and I had a chat before he went on leave. So I'm just going to pull out the things that he asked me to highlight. So the first of those is the progress with the COVID-19 vaccination programme and the policy to ensure that all healthcare workers in NHS organisations are vaccinated ahead of a deadline of the 1st of April 2022. So important to note that we've done really well with this, and the vast majority of our staff have already had 2 vaccines, many of them just receiving boosters, and that will continue. For the small proportion of staff who haven't received the vaccine through choice, we're in the process of having one conversations with them through both a line management route and also through a clinical route to make sure that people are making truly informed choices around what vaccine options are open to them. And Gertie and team are in the process of agreeing what a policy will look like for the management of staff who continue not to want to have a vaccine as we head through into the new year and won't meet that deadline. And as we have more news on that, and that's agreed through various staff side committees, we'll be able to share that and be clear. The paper also highlights the significant effectiveness of the vaccines, and particularly the AZ and Pfizer combination with the booster from Pfizer developing significant levels of immunity. And so I think really important just to take the opportunity to once again promote the public health message associated with vaccination, and to make sure that everybody really gives some serious thought to this. The vaccine is really effective, it's really safe, and we encourage everybody to have a vaccination. That includes the booster programme. And of course, since the paper was written, we've heard some changes to national policy following recommendations from the Joint Committee on Vaccinations and Immunisations. And we will very shortly be offering vaccine boosters to all adults, everyone who's greater than 18 years old, and they're busy just configuring the booking systems to allow people to take that step. And also a reduction in time from the second dose to booster, and that's reduced from 6 months to 3 months. So encouraging all of our staff, every member of the public, anybody who might come across this video recording or read about things that might be picked up in the press to go and get their vaccination and their booster. Contained within the update, there's a detailed explanation of developments in the foundation group, based on the fact that it has been extremely successful, and setting out how we intend to build on its success going forward. And that includes consolidating the work of the group across Wye Valley, George Eliot and Swift, but also the fact that we've invited Worcester Acute Hospitals to join the group as associate members. And the paper goes on to set out what the governance arrangements around all of that will look like going forward. It's quite detailed, a lot of information in there. Don't intend to go into it in any detail, but I think really helpful for the board to be able to see all of that set out so clearly. You mentioned against the action log something about the industrial action and IT transfer, and the transfer has actually now taken place. The trade unions have suspended strike action. They continue to be in dispute with us, and discussions continue about what's going to happen next, but important to recall that the transfer did take place as planned on the 1st of December. There's a paper appended to the Chief Exec's report just detailing some assurance that we received around a cleanliness assurance visit. And this is included in the Chief Exec's paper following discussions in various meetings and committees where previously we've identified that we'd not been compliant with some audit work that needed to be done to demonstrate compliance with cleaning standards. That resulted in a visit, and the output of that visit, which is positive, is included in the report. And we're now back on track with our audit programme and submitting against the deadlines associated with that. So hopefully that's that issue dealt with. The paper contains an update from our Women's and Children's Directorate and some useful and interesting information there. There's also reference to Appreciation Week, and I think important as we go into the board meeting just to recognise the fact that our staff have worked incredibly hard through the pandemic and continue to do so. So we held an Appreciation Week from the 22nd to the 9th of November. We had all sorts of activities on the go across the hospital to celebrate the investment that our staff have made in making sure that our patients stayed safe and were able to look after and care for our population through the pandemic. And that included the unveiling of a piece of artwork and the dedication of some space in the Faith Centre garden. And if people are on site and they're able to go and have a look, it's well worth a look. The artwork was supported by the George Eliot Hospital charity, commissioned by the hospital, and produced by an artist called Kerry Lemon, who's based in Brighton. It draws on inspiration from Warwickshire and from the hospital, and it's a lovely place to go and sit. It was built and constructed so that it can be used to make a rubbing. So if people want to use that as a token of remembrance or thoughtfulness and reflection after all that we've been through, it's a really interactive piece. And it was a real privilege for me to be there to help with the ribbon cutting and to open that for people to go and have a look at. And then finally, as you mentioned, just wanted to put on record, Russell, my and the executive team's thanks to Stephen for his exceptional hard work as Chief Operating Officer, and sorry to see him go. This is his last board meeting, but just want to put on record our deep thanks for all that he's done in his time here as COO, and clearly to welcome Patrick to the team in his interim capacity. And I'll stop there and take any questions that there might be.
Well, what a summarise. Thank you, David. Any questions or perspectives on Glenn's report? Julie?
Just a couple, and thanks very much, David, for presenting a really good report again. The one is around COVID vaccination, and it's good to hear the one-to-one conversations that are being held with people who are nervous about vaccination. I suppose, given your comments about the importance of the booster jab, I just would like to get a feel for how many of our staff have had the booster, and just a bit confused as to why full vaccination by February doesn't include the booster, given the press that's there at the moment. And just very quickly, in terms of the list attached of all of the people and all of the teams that have been seen, I did visit outpatients with Caroline Hughes. I wouldn't want them not to be included to know that we had a visit with them, and that was on the 23rd of November. But importantly, my first question, please.
Yeah, so we'll make sure that the outpatients visit is captured, Julie. Sorry about that. So Gertie's probably best placed to give us numbers. And I believe that the decision about the definition of fully vaccinated is a national policy definition being applied across the board. Gertie, don't know whether you're able to help any more with that or the numbers question.
Yeah, absolutely. So I've just looked at the regional reporting this morning, Julie, and what's really positive is George Eliot from a frontline worker perspective is showing at first dose at 95%, second dose at 93%. In terms of the booster vaccination, we are working on validating the data we have, because what we do know about the booster is that an awful lot of our colleagues were vaccinated elsewhere, and not all of the national systems are able to speak to each other. So we're going through a process at the moment moment of contacting colleagues about whom we don't have a status update for them on their vaccination. At the moment, our vaccination is standing at around about 74%, although we know that our actual vaccination statistics are much higher because of the number of staff who have had them either at their GP or in a local centre. So we're working on maximising and pulling back our data through on that. As David said, it's absolutely right. The law surrounding healthcare workers and those with patient-facing contact is only on vaccination dose 1 and 2. It doesn't include the booster, and based on the guidance that was published yesterday, it's still not showing that it's likely to pick up the booster in that. Have I covered everything, Julie, or did you need anything else?
That's great. Thank you, Jim. Thank you, Gertie. Any other questions? Otherwise, we'll move on. Quite a lot to cover as normal, guys. Thank you. So the maternity services risk management strategy. Darjit, thank you for this. What would you like to pull out?
Yeah, thank you, Chair. So we're bringing the strategy here in line with best practice. We review it once a year and then bring it to Trust Board. The report has been to Audit Committee, but because of timescales, it hadn't gone to the Women's and Children's Governance meeting until yesterday. And it was felt that the delay, given the board meeting is in February, that board should have sight of it today. I've now been in touch with the team and they would like to make some changes to the strategy. They're not significant changes. What they will do is further describe what the governance meeting processes are within the appendices. In addition to that, as part of our ongoing work with the LMNS and to also strengthen governance in maternity, I've actually asked the team to pull together a governance framework for maternity, which we believe will also be ready within the next month. So what I'm proposing is that I bring this back to the board meeting in February, along with the governance framework and the detail of the governance meetings, which will update the, I think it's Appendix D in the strategy, and also ensure that before it comes back to board, that it goes to the Executive Risk Committee and to the Audit Committee. And I would suggest that that would give us a more meaningful discussion at board to enable us to ratify this.
Okay, that's great. Sounds very wise, Darjit. But any immediate comments from colleagues having read this version? All seems very sensible to me, Darjit, but obviously very important. So in summary, we'll see it again in its final version in February, and we look forward to that, and we've gone through the various appropriate internal processes in the meanwhile. Thank you, Darjit. So if there are no other questions on that, I can't see any digital hands. We'll move on to the Estates Quarter 2 report. Stephen?
Yeah, just pull out a couple of things. I think the first thing to say is you'll get a flavour from the report of not only the depth of capital work that we're doing and the quantity of it, but also in terms of the ICS and the capital plans that we're being asked to submit at a kind of a frequent and quite short notice basis. You can see there from the list that there's quite a number of schemes that we've put forward of varying values. There's no guarantee to them, but I think we're trying the best to get as much capital onto the site, which is well needed. One bit that's not in the paper that I just want to make board members aware of, because it will start to feed through into next year, is that we've just commissioned a consultancy. It was one that was used at South Warwick, and I think was quite successful, to have a look at developing an estates plan and estates strategy, and we'll also look at making sure that we're maximising all the clinical space that we can. So we're using them probably more from a capacity point of view, but that work will ongoing, and I'm sure that'll feed back through to board at some point. Just in terms of all the work that you can see that we've got going on the capital programme, just want to pull through 2 or 3 really, and I guess the theme is we're trying to tackle some of those long-standing issues. So the 2 that I want to pull out are the maternity theatre refurbishment, which has been a long-standing issue and sat on the risk register for quite a while with Women's and Children's. There's a well developed project plan to take place in that, so we'll be dealing with that in the new year. And the other one, and now when we are allowed to have more visits, I would definitely encourage, and I think some people did go to accident and emergency because we've done a big refurbishment down there. And certainly if you go there, it looks pretty impressive, and actually the department starts to look completely different to what it was before. And the feedback from the staff is brilliant around that. So that's a real successful one that we've done. And the last one I just wanted to pull out in terms of the capital work programme, you'll see it on the site, and again it's a really exciting opportunity for the hospital and for places around CDH work, so you can see where it is. There's a lot of movement, a lot of activity going on around there, so again that's a real positive one, and that's progressing at pace. And I guess really just the only thing that I just want to draw out in terms of risk is kind of the capacity to deliver. So I've been working with David and we've been looking at the estate structure, and there's also conversations happening across the two trusts with South Warwick about how we can mitigate that off. We've done it in some areas such as EBME, but that's the bits I wanted to pull out, Russell. Happy to take any questions.
That's great, thank you, Stephen. And we've achieved an awful lot over the last couple of years during your tenure, so well done. Any questions on the estates report from colleagues? Please raise a digital hand. Julie?
Sorry, Russell. Thanks, Stephen. Just very, very quickly, if further targeted investment funding becomes available, how do we prioritise which schemes to take forward if that happens?
Yes, so the TIF, as it was called, Targeted Investment Fund, there was a very specific set of criteria around it, which doesn't quite come through there. So you had to be able to spend it by March, and it had to have a direct impact on elective recovery. So what we've done is kind of mine the capital programme for the next couple of years to see if there's things that we will get onto that we could bring forward, plus if the directorate think there are anything else that would help. So what you'll see on there was kind of we were able to deliver it within that time period. So that's how we've looked at that. If it changed, so the time period was longer, we'd just go through probably some of those other schemes that we've got on the front sheet and the capital programmes. That's the balance that we're trying to take, really.
Okay, thank you, Stephen. Thank you, Julie. And any other questions on the estate side? Just remind me, Stephen, obviously things have changed a bit, but the League of Friends and the canteen area, where are we with monies and that development?
It's all ready to go. Once they're able to get back on site properly, we'll just get that one moving. It's all set.
That's great, thank you. Okay, colleagues, happy to move on. So Hack will kindly sort of just brief us on where we got to on the final planning submission. Certainly on my screen, Hack, you do look like an airline pilot who's just about to land an A377 at Heathrow with those headphones and microphone. So over to you, pilot Hack.
Thank you. Yeah, working from home today, so yeah, I've had to put the headphones on to not disturb the rest of the family. So the report you've got in front of you is a summary of the final plan for the second half of the year that was agreed with me by Russell and Glenn in line with the delegated authority that was granted by the board. So this report is here for information. It updates the report that was presented here last time and pulls out the key areas to note. Really, so the key, there's only minor changes to the financials and no change to the activity submission. The key points to note relate to confirmation of funding in relation to some of the assumptions that we'd actually made in the draft plan around winter costs and around the recovery funding, which has now all been agreed. And as stated last time, our key aim is to be able to treat as many patients as we possibly can from our waiting list within the staffing constraints and bed availability, and we expect to deliver the minimum performance requirements that were set out in the planning guidance. And finally, in terms of capital funding, as we've just noted, £1 million was agreed from the targeted investment fund. So all the bids we put forward were agreed. So the board is asked to note the final plan submission and the key changes from the draft version.
No, thank you, Hack, and I know an awful lot of work's gone on behind the scenes on this. Any questions on the final submission? Okay, so Julie approved. Thank you very much, Hack. And then keeping on the theme, FAB reminds me of Thunderbirds when I was a child. The FAB change, I can see some giggles from those of a certain age remembering Thunderbirds and Troy and Stacey and everything. So Jenny, the FAB change, please.
Yes, thank you. So just to say that this is Fab Change Day. We fully engaged with Fab Change this year as we did last year. This year it also coincided with Appreciation Week, which was a really positive opportunity to appreciate people's changes and projects and the things that they'd done, and also the fact that people have taken time to share those and share the learning that came out of those. So this report just really sets out a reminder of what Fab Change Day is and what it's all about, which is celebrating those changes that can be small or large in terms of our improvement journey, and how we've sort of linked that into our approach to improvement stories. And then the report goes on to just list a number of those submissions that came through. And I think what's really impressive is the variety of submissions that came through from across the organisation, and the key themes that were absolutely clear from looking at the totality was the teamwork and the sort of can-do attitude that was a theme throughout. And so yeah, so I commend the report to you. Hopefully you've had the opportunity to look at some of the sound bites, and I hope you saw some of the tweets that went out, and we had a significant reach with the tweets that were made, and so it was a really good exercise, and I hope that people have the opportunity to see that. We've also had quite a lot of feedback from people that received the follow-up letters of thanks, just to acknowledge that that meant a lot to them to receive that, and that their work was being shared with you at board today. So thank you for that.
Thank you, Jane. Thank you to everyone involved in the FAB work, and those that have come up with a multitude, as you say, Jenny, of really great ideas. Any questions or perspectives? Rebecca?
Thank you, Chair. Really positive work, Jenny, and fully comprehensive, that shows the profile of our organisation. Just wondering, how have you gone about archiving these projects so that we can very quickly disseminate and access the good practice in the future, please? Thank you.
Yeah, actually, that's a really timely question for us. So, and we were actually discussing this the other day, the improvement board, on the back of this. At the moment, we've got a sort of a bit of a manual system about it, sort of, and we, if you remember last year, we used that to do that compilation on the video where we did some talking heads with people. So we intend to do some of that as well. But we have also got a platform that we're developing that has got some space where we can share these stories, so that it actually, so it's not quite an archive, but it's more like a platform that people can go into and link on and sort of look for stories in particular areas or particular themes. And we're still developing that, so there's more to do, but we'll be using some of this material to put onto that platform and to develop that search engine, if you like, for those improvement stories. But hopefully, as part of the annual report as well, you'll see some of the compilations and the people behind the stories in that sort of visual way, like we did last time.
Thank you.
Great question, Rebecca. Thank you. Thanks, Jenny. And any other questions or perspectives? So this will now effectively become an annual thing, won't it, Jenny?
Yes, it seems to be an annual thing, and it's linked into our celebration, and I think the learning from appreciation would take forward as well, because I think I'd like to link that into Fab and appreciation, be mutually supportive of each other.
Okay, great. Thank you very much, Jenny. Colleagues, happy to move on to the quality side of our agenda. So Daljit, I think first of all, on the report on safe nursing and midwifery staffing, over to you.
Thank you very much, Chair. As discussed at Board Development Workshop this morning, staffing continues to be a challenge and is quite significant in terms of nursing and midwifery. And this monthly report will just describe some of the operational challenges we're having. We continue to put the mitigations in place to ensure that we spread the risk across the hospital and keep the wards safe. In October, we had 22 day texts reported. 3 of those were low harm, and they had mitigations in place with support from the matron as well. We saw a slight decrease from previous month in relation to number of our staff absences associated with COVID. That was nearly 98 whole-time equivalent. But for information, November and early December is proving to be quite challenging. In terms of our vacancy rates, for our registered nurse and registered midwives and nursing associates, not including band 8A and above, we've got around 53 whole-time equivalents vacancies. Around 35 of those are band 5, and that comes with the context that these numbers include posts that have been pointed to and have not yet started. And for healthcare support workers, we've now got round about 19 whole-time equivalent vacancies. And again, this includes staff who have been appointed but have not yet started. I particularly just want to draw out intensive care, who have continued to operate over capacity due to increased activity in October, and also, you know, to accommodate elective activity across the trust. The trust has been in a position where they've offered mutual support to other units who are busy, which is obviously added to that additional capacity that we're running. And we have started to see a slight increase in our COVID cases within ITU, which is concerning, but this ties in with the directly with the increase in the virus which is circulating in the community at this point. Midwifery staffing has also continued to be a challenge, and we've used the escalation policy, which has ensured that we've continued to deliver one-to-one care in labour at 100% throughout these challenging times. There was a decrease in the red flags being reported, and these were 25 of them. 24 were due to a coordinator not being supernumerary. 1 was due to delayed care, which was following vaginal birth and perineal suturing delay, and there was no harm attributed to that, and the manager on call was aware of this at the time. The birth rate, the midwife to birth rate has improved slightly. We're now in 1 in 29, and that's due to the fact that there has been a decrease in birth, and we've also had additional staff start, and sickness has improved slightly. I just also wanted to pull out our plans around international recruitment. This morning, clearly at the workshop, we talked about our challenge to recruit to our registered nurses, and we have currently been doing some work on Strand C. And Strand C is essentially where you support international nurses who are already working as perhaps healthcare assistants to become registered nurses, and this has been really positive. So in terms of Strand 3C, we are in the process of supporting these colleagues in their OSCE programs, which are the objective structured clinical examination they need to pass in order to be registered. Due to the number of registered nurse vacancies, we have now decided to work with South Warwickshire to explore options relating to the Strand B agreement in place between our trusts. And that is where we go out to fresh recruitment for international nurses. Currently, the discussion with NHS England is that we look to recruiting 12 nurses being in post by the end of this financial year, as per our original contractual agreement with NHSE. Happy to take any questions.
Very comprehensive, and we appreciate, Daljit, the challenges in the whole area of nursing, and we greatly appreciate your leadership and wisdom and calmness and the challenges that you face and your team face. Any questions or perspectives to Daljit? Simone?
Thank you, Chair. Daljit, it's just the same point I made in the workshop this morning, which is, can we separate out the nursing numbers and midwifery numbers, please? Yeah. Thank you.
They're all further down in the report, but I think they're putting it on the table, so I didn't note that, of course. Yeah.
Thank you. Thanks.
Thanks, Simone. And Rebecca?
Thank you, Chair. Daljit, just seeking a bit further assurance here. How can the Trust be assured that staffing shortages don't impact on the ability to support newly qualified nurses and midwives and also supervised students? What safeguards are we putting in? Thank you.
Thank you. Thank you, Rebecca. Well, currently we've still got our practice development team are still running their routine work, so they are able to support. That will become a challenge if we did what we did in the pandemic at the beginning, was where we asked our nurses that are working in non-clinical roles to come out and support. And now we might need to look at doing that in some point if this increasing pressure continues. And I think at that point that becomes a risk to us. And a part of the well-being check that the wards do and the matrons do is to check upon our students to see how they are. And in the morning huddles, that's a part of discussion that we have to make sure that we are alerted to where our student nurses are. Our aim is that those student nurses don't move around the wards, they stay where they are with their regular ward team, so they get that level of support. But it will be an increasing challenge. We do have a strong preceptorship programme which we're managing to support them with. That's our newly qualified nurses as well, which we're very mindful of the support that they need. So whilst we've got those programmes running, we can support them in the way that they will get that additional support from the practice development team.
Thank you.
It must obviously be a real challenge to get the balance right, and I think we just need to recognise that and apologise for it, but it's just a reality we live in. And as you mentioned, I think, Simone, in this morning's workshop, we had a good discussion on our success over the last year in terms of recruitment, but with new theatres, increased capacity, we still have the vacancies that Darjit's been talking about. Are colleagues happy to move on? So Darjit, could you just cover off the report on acuity and dependency reviews, please?
Yes, of course, Chair, thank you. So this report is our second report in the year. Good practice is that we do two acuity reviews every year, one in winter, one in summer. So this one reports on July. The next one will start collecting the data for January. The review, summary of the review is that we have 12 out of our 12 adult inpatient wards, 9 of the wards have a higher nursing staff establishment than recommended by the Safer Nursing Care Tool, and 3 are lower. But I really do caution our interpretation in this. In interpreting the report, the board is asked to take into account that we were operating in COVID times at that time. We had ring-fence beds for COVID, and our occupancy rate was only 89% at that point. We also noted that there were some wards who had not completed the tool correctly. The other caution in explaining this report compared to the discussion we've just had is that this report is looking at the nursing establishments, not looking at the daily operational pressure. So there is a huge difference. It might look that one end we're having a conversation that we haven't got enough nursing staff, and then we're saying, oh, we're over established. But the assurance that I can provide to the board is that, you know, obviously we move our staff around on those areas where the establishment might be slightly higher, so we can support areas that are strong. So in terms of the results and how they're interpreted, as well as looking at the data, the Associate Director of Nursing and the matrons and the ward managers also meet to do that professional judgment check on the staffing, because numbers alone don't tell you everything, but the feel of the ward and professional opinion is really key in this. It also, a part of that, we look at our care quality indicators as well. So we look at our quality data, things like falls, pressure ulcers, etc., to make sure that we're not missing anything. So those were completed following the July review. And in addition to this, there are some areas where this tool, the Safer Nursing Care Tool, doesn't apply. They're mentioned in the report, but also assurance is given that we've had professional judgment meetings with those ward areas and those departments to make sure that any mitigations around establishments are being considered. There isn't a tool, Safer Nursing Care Tool, for ED at the moment, but they have just published one. So we are hoping to get updated on that and to do our training on that, so that in January we'll be able to use the tool to do, for the first time, a Safer Nursing Care Tool audit for ED. In terms of maternity, there's been a review of the acuity data reporting tool in line with Birth Rate Plus, and what we're looking at doing is developing a Birth Rate Plus specific acuity review tool that we can then use twice a year, as we do for the Safer Nursing Care tool. The Birth Rate Plus national recommendation is you don't need to do the full review because it's actually quite a complex, lengthy thing to do every 2 to 3 years. And the board is reminded that we did one last year. But our decision is that we would like to do something a bit more detailed other than a tabletop review at least twice a year. The report highlights some of the challenges that we're having in the Children's Assessment Unit, and this is due to recruitment of paediatric nurses, and this is a national issue. And the report describes that we've really reviewed that workforce model to include nursing associates, which is proving to be very positive, and also looking at introducing ACP roles to support, in particular, the potential increase that we're expecting to see in RSV. In terms of ITU, we discussed earlier the increase in the acuity due to COVID. We had already submitted a business case which has been approved for 5 whole-time equivalent Band 3 assistant practitioners. 3 of those are now in proposed and 2 we are recruiting to. So, and in terms of the conclusion, as per our previous acuity reviews, we are recommending that there's no further work to be done in terms of changing the establishments at this point. What we would like to look at is increasing ward manager supervisory time and the professional nurse development time within the directorates themselves, and to also look at centralisation of maternity leave. There has been some delay in looking at this because our focus has really been on the day-to-day safe staffing and the recruitment. The board is assured that this delay hasn't caused any direct patient safety impact, although it should be recognised that these actions would enable us to make longer term quality improvements.
Very comprehensive overview. Thank you, Daljit. And please thank Jeanette and Claire for their work in this regard. Any questions or perspectives to Daljit? Glynis?
Thank you. Daljit, thank you. That's a really helpful report, and I think there's some really good ideas in terms of how we can improve quality when we're looking at workforce. But can I just ask you about the introduction of the long days on all the ward areas in light of the challenges we've got with recruiting workforce? Is this having any impact on our recruitment, attracting staff when it's only long days?
There's no evidence that it is, and I think that what we do recognise is there's still some flexibility in there. We're not turning staff away if they can't do those shifts. I want to emphasise that. There's still that flexibility in there. What we did on our transformational work a couple of years ago is there was so much variation in the trust and so much overlap that we wanted to create that greater efficiency. I think overall our workforce, I think our staff have now sort of accustomed to that shift, but we also recognise it doesn't suit everybody. And as our discussions we had at board this morning regarding, you know, the nurses that might want to retire and return, I think we've got to be a lot more flexible going forward. And I don't think we're going out saying that, you know, nurses can only work these shifts. We'll be flexible to try and meet the, you know, the needs of the individual staff members. Certainly hasn't been raised as an issue as to why people would not want to come and work at George Eliot.
Thank you, that's helpful. And I think your point about the older nurses, speaking for myself, I think 12 is appealing, but might be something just to bear in mind.
Yeah.
Spring chicken, Daljit, you're a spring chicken. Any other questions or perspectives? Otherwise, we'll move on to the integrated performance dashboard. Okay, Glynis, if you could take your legacy hand down, that would be great. So, David, over to you for the summary, please.
Thanks, Russell. So just a quick canter through the integrated performance report. And again, just to remind people that this follows a series of finance and performance executive meetings, which are led by the exec with Ned in attendance. I've got a feeling I may have dropped out. Russell, can you hear me?
We can now, David.
Can hear you, but you're not moving.
Okay, can you hear me now?
Yeah.
Okay, I'll keep going. You've all frozen on my screen. If you can't hear me, indicate somehow.
No, we can hear you. You've frozen on our screen, but just continue, please.
Okay, I'll keep going, Russell. Thank you. So just reminding about the connection through the finance and performance executive. So the actual performance, the data that sits within there, mortality is the first indicator that's reported in there, and a strong position there with 88.8% against HSMR, and that follows some significant success in delivering the mortality action plan under Catherine's leadership, and is really good to see. Moving into clinical quality indicators, I've covered cleaning, so I won't go there again. Infection prevention and control, no cases of MRSA to report, and 2 cases of C. diff, which are currently subject to full review and report to QAC, so that will follow in due course. We've seen an increase in the number of falls, 41 of which were unavoidable out of a total of 52, and there were no harms as a result, but all of our falls are reviewed quite comprehensively, and any learning from events taken very seriously and communicated around the organisation. We had 1 avoidable category 2 pressure ulcer, and review identified that related to an intravenous line placement. Learning was shared from that, and our complaints performance is pretty strong in terms of being able to hit the deadline for complaint turnaround. And we have seen a reduction in levels of positive feedback across the range of friends and family tests. We think that probably relates to the circumstances that we find ourselves with in the hospital and the situation that we find ourselves in. But we're continuing to get underneath that and to investigate and make sure that we're not missing anything. In terms of operational performance, some of these numbers relate to October, some to September, depending on the measure. A&E remains very busy with a significant number of attendances, 8,206. That's a slight reduction in previous months, but still significantly over the pre-COVID level of attendance. A greater proportion of those patients are majors, which require the trust to admit the patients, and so that has a significant impact on flow and hospital occupancy, and that's in turn impacted on 4-hour performance. We still, however, are managing to, in relative terms, perform reasonably well. So although performance is 84.3% and 10% below the national standard, we're still best in the region and 4th nationally. We did have a number of over-hour ambulance delays with 17 patients, but I think I'm absolutely assured on the grip that's in place around that. And when that does happen, it is a true barometer of pressure in the urgent emergency care system and needs to be seen in that context. And we didn't have any 12-hour delays to get patients into beds, which many other organisations are suffering with. In terms of elective care, recovery continues to be challenging, and staffing pressures and urgent and emergency care demand are driving that. You can see from the report, though, that in terms of elective activity and day case activity, we're well above the 1920 benchmark that we've been set. Our outpatient activity is below the benchmark, and that really is something that we need to understand and will, I think, be reviewed as part of the elective care strategy that's taken place nationally, with a drive to do fewer follow-ups and to move away from hospital-based to virtual appointments. So I think we'll see those targets shift as we start to get underneath that. And you can see in the paper that there's a new target relating to clock stops, where 89% of people seen have a procedure, have their clock stop for a first definitive treatment, and we're achieving that in both the admitted and non-admitted pathways. Overall performance against the 18-week standard is 68% thereabouts, and we're obviously seeing that deteriorate a little bit as the pressure comes back on. We'll continue to pursue that improvement over the coming months, although we need to be realistic about expectations as we move into the winter months, likely to stay where it is rather than significantly improve. But what we will do is make sure that anybody who's waiting for a long time is cleared from the waiting lists, and we've got 2 standards around 104 weeks and 52 weeks, which are on track to deliver against clearances in December and March, respectively. Diagnostics remains a little below the 92.9, the 99% standard at 92.9, and we've got an improvement plan in place for that, and we expect that to improve from the beginning of the new year through January and February and into the beginning of the new financial year. Stroke performance continues to be a challenge, as it has been for a long time, and that's well rehearsed here. That's for no other reason that, again, we're continually under pressure and facing difficulties getting patients into the right bed. We've had a number of solutions attempted to try and resolve that, and it is a very stubborn measure to shift positively, but we, again, haven't given up, and we continue to focus on that. And from a cancer perspective, we achieved 60% against the 62-day standard for this reporting period. And there are some significant challenges in there in terms of tertiary components and involvement of partnerships with increased demand, and in particular with our tertiary partner at UHCW. And we are in discussion with them about how we improve that. And to be fair to them, they have seen increased demand across the piece, which is driving some of that problem. So there's quite a comprehensive set of conversations underway to try and deal with that. We've got 6 patients over 104 days, and that's a slight increase on previous months, but we continue to case manage those patients. And we've also seen some deterioration in 2-week weight performance, particularly in upper and lower GI cancer sites, and that's associated with an increase in demand. From a workforce perspective, a slight reduction in the vacancy factor to 7.5% from 8.1%. Reflecting successful recruitment into particularly band 5 vacancies, which is very positive given the difficulty of recruiting into that type of vacancy. And also, I think important to just relate that to the conversation we just had about increasing establishments. So we've recruited more people, but we've put more posts into the establishment, and therefore the vacancy percentage hasn't changed as dramatically as it otherwise would. We are dealing with some deanery gaps through junior doctor rotations, and sickness and absence continues to be a challenge for us. So reported at 5.7% here, but some days higher than that. So today, just looking at it, a little over 7%. So still a challenge for us. And I think I'll pause there. Hopefully you can still hear me. I can't see anybody moving on the screen. So Russell, over to you to coordinate some questions.
No, great. Thank you, David. We heard all of that, but you are frozen on our screen. Any questions on perspectives to David? David, just one from me. Can you, the ED performance in context is exceptional. Can you please pass on the board's thanks to the leadership and everyone on the front line in the ED department for the extraordinary work that they're doing and coping with at the moment? Stephen, do you want to add anything to that before I move on to Rebecca?
Yeah, it was just for context for board members, it'll work its way through the governance route, but in terms of stroke, we do a snap audit, which kind of gives you a scale. I'm really pleased to report, despite the challenges around the bed occupancy target, that it looks like we're reporting it being a level B, which is the highest we've been for a number of, well, certainly since I've been here. So that puts it in context, because I know one of the questions that I regularly get is, how can we be assured that we're giving the standard of care that we should, even if the patient might not exactly be in the right place? And that's a really good indicator of the work that the team are doing. So I think if we can just tackle that last bit, that puts us in a really good place.
That's great, Stephen, and Patrick, you will have the shoulders to take that forward on the board's behalf. We've lost David at the moment. Hopefully he'll be back in a second. But Rebecca, what was your question?
Thanks, Chair. So my question is in regard to patient weights. How are patients informed that they're being prioritised based on clinical need and not chronological order?
You mean particularly in the elective side, Rebecca?
Yes, thank you.
Stephen?
Yeah, so all the patients, there's a regular kind of clinical prioritisation call that they get with a clinician, and we're just about to do an online form as well, which it describes that to you. So we talk that through with the patient. So what they're able to do is understand if it looks, particularly in somewhere like Nuneaton, they may know somebody who's waiting for someone else and it appears they've gone quicker. So when the clinician goes through it, that's a script that they run through.
That's really useful. Thank you. Thank you.
Thank you, Rebecca. And obviously an absolutely key issue to our citizens. So it's one of the most worrying times, and you want to understand the prioritisation process. Any other questions on the integrated performance dashboard? Good to have you back, David. Okay, so we'll move on then quickly to the finance report and month 7. Captain Hack.
Thank you. Yeah, so this was a bit of a tricky month to report on because we were still finalising the plan at the time, so the numbers were moving and have moved since we wrote that report that's in front of you. So the report shows a deficit of £600,000 in October. But as mentioned earlier on in the planning paper, we have had the recovery funding agreed. So that's £500,000 of additional income for October. So that means our true position for October would be a deficit of £100,000 only, and that relates to some slight under delivery on our CPIP target or against our CPIP target. And that is a key risk to delivering the financial position really for the rest of this financial year. It is that CPIP target. So we're about £1 million short at the moment in terms of plans against our £4.2 million target. The directors are actively working on plugging that gap, and they are reasonably confident over the next couple of weeks they will get there. So on that basis, I'm reasonably confident that we will recover the £1.3 million deficit from the first half of the year and deliver a break-even position for the full year. Just briefly on capital, our expenditure is still behind plan, but it's increasing. And you saw from Stephen's estates report that we've got a number of major estates projects on the go. So even though we are actually spending the money, that expenditure won't hit the accounts until we reach certain milestones on those projects, which we haven't done as yet. So just to give you assurance that we are actively spending the money, even if it's not showing through in the accounts just yet. So we're forecasting we'll spend all of our capital allocation, but slight note of caution around that in terms of there is significant risk of slippage due to supply chain issues, but that's countered by inflationary pressures as well. We do have a plan B if there is any slippage, and that is to pull forward some essential expenditure from the next financial year. So essential equipment replacement or maintenance work we will pull forward. So one way or the other, we will make sure we will spend our full capital allocation for this financial year. And we have put in additional measures to manage and track the expenditure more closely and provide additional support to the SROs to make sure that we do deliver on our plans. I'll leave it there. Take any questions.
Oh, that's great. Thank you, Hack. Any questions or perspectives to Hack? Thank you for the clarification on the elective recovery fund being covered in the £500,000. Okay, so it's important for executive colleagues to plug that CPIP gap so we do break even. That's very much what we need to achieve. David, I think we're then on to the summary of ratified policies, please.
Yeah, thanks, Russell. So the paper speaks for itself. I won't spend any time on this. So the meeting was cancelled on the 29th of October. I took chair's action outside of the meeting to ratify the policy that's noted there, and it'll be formally recorded through the next meeting just as a matter of record.
Okay, thank you, David. Any questions from colleagues to David on that? Okie dokie. So the annual schedule of board business and calendar of meetings. Sarah.
Thank you, Russell. So the report outlines the business that the board can expect to receive during 22-23, but it doesn't preclude the board from making any changes or additions where required. Also outlined in the report are the proposed meeting dates for the board and board committee meetings during 22-23, but it is worth noting that there will be some changes to the board dates to accommodate the Foundation Group quarterly board meetings, which are yet to be confirmed. So happy to take the recommendations as outlined on the front sheet.
Okay, great. Thank you, Sarah. And coordination of that with your colleagues. It's never an easy task. Any questions or perspectives on the schedule of board business and calendar of meetings? Rebecca?
Thanks, Russell. A quick one. Given the discussion that we had this morning at board in regards to health and wellbeing of staff and the role of the board in supporting that, in regards to our schedule of business, when will board be cited during the year on our performance in this area, please?
Great question, Rebecca. Gertie, did you? I know you've only just come back into the meeting. Gertie, did you hear the question?
Yes, I did. Thank you, Chair. My intention, Becca, would have been to have used at least a proportion of 2 of the quarterly people updates to update board again. And I think then there's a separate conversation about whether or not there's a biannual reporting to public board. But obviously we haven't got that far yet. So I think we would have a conversation with Sarah in the new year about potentially a public board update biannually.
I think it'd be useful to make sure that we are signposting that publicly.
Absolutely, yes. Thank you, Becca.
No, I agree with Becca, particularly given our responsibilities as an anchor institution. So if we can work on the basis there will be a bi-monthly public board update on that, that would be good. And any other question on the schedule of meetings? Colleagues therefore happy to approve. If you're not happy to approve, please raise a digital hand. Okay, great, thank you. So we'll move on then to the Freedom to Speak Up Quarter 2 report. So lovely to see you again.
Thank you, Chair. I'll take the report as read. Just a couple of highlight areas. You'll see there's a bit of a spike in the Women and Children's Division Directorate this time. Most of those come from sexual health, which we've pulled out for a little bit more detail in the report. And that was as part of a walk around that Deepa, our Freedom to Speak Up advisor, had done on site with the team. So there were quite a few concerns that had come from that team on that day. So that's why there's been a bit of a spike there. You can see from the themes that the usual hotspot areas are there around attitudes, behaviours, staffing levels particularly are being pulled out over this last few weeks. And so interesting to hear Daljit's report earlier about safe staffing. And that's definitely a theme coming through probably across the system, not just the trust really, that staff are feeling the pinch. Some positives, the work around radiology has continued, and it's coming to its final part of Speak Up at the moment. We've done the feedback to staff. We've done an all user letter as a response to some of the whistleblowing that we had from that department. We've got some new ambassadors in that team, and we're continuing to work with things like the civility campaign and getting them back on track. Civility continues to be rolled out across the trust. The uptake is good and the feedback is really positive. We've done a mixture of bespoke sessions and generic sessions, which all staff can book onto. The next bespoke session I'm doing will be with Catherine again, and that's for the anaesthetics and the theatres teams after some concerns that we had within that team during last quarter. And then our ambassadors, we're recruiting new ambassadors. We've refreshed the ambassador programme, so they're now Speak Up, Wellbeing and Inclusion focused. And there's some work in the pipeline to support them more with some pastoral care, linking in with staff in mind, and also with Warwickshire County Council to continue their training and their development as well. And I suppose new highlight that isn't in the report is that we're just working with the Datex team across Swift and George Eliot at the moment to try and change the way we report our data so that it's on a Datex system for Speak Up rather than it being on a database that Deepa and I hold, just to try and make that a bit safer and a bit more secure, and as another way for people to flag their concerns with us as well, rather than just the email and the usual route. So hopefully that'll improve reporting as well going forward. So happy to take questions.
Yeah, thank you for your hard work. You're an absolute star. Questions or perspectives, Simone?
Thank you. Thanks, Sue. We always enjoy reading your reports. They're very informative. Can you just remind me how the things that you collect are fed into the normal directorate assurance processes? So just thinking about that spike in women's and children's, how would we then see that feeding through into the reports that we see at QUAC about staffing, for example?
Hopefully the divisional or the directorate leaders would take that through QUAC on my behalf. It'll go through Trust Management Board as well, and more detail can be teased out in Trust Management Board paper as well for some specific areas, so we can discuss that further.
In terms of any actions, I'd expect the Directorate leads as well to be owning the action for their division, and taking any recommendations forward, and then I'd try and get assurance from them that those actions have been put in place and that any wider learning then is disseminated. And I'd expect the usual channels like QAC through the workforce team as well to pick up any issues that are around staffing and HRE issues. Possibly could be a little bit more tight and each directorate is different for that.
Yeah, so I think there's work to do, isn't there, on triangulation. It's a collective responsibility. It's not just yours, but seeing how some of these feed through into IPR and directorate reports would be really useful. So thank you.
Okay, thank you, Simone.
Thank you, Sue. Thank you, Simone. And Rebecca?
Thank you, Chair. Thank you, Sue, and to yourself, and also to Deepa for all the work that you're leading. This is really positive for us and for the trust. I note about the refresh in regards to our ambassadors and the ambassador network. So my question is, how do you know whether the methods in use to promote and publicise the role of these ambassadors to all staff, so including our volunteers, students and contracted temporary staff, is working? How will you know?
So potentially an increase in reporting through the ambassador route or through signposting. Also, we do the feedback questionnaires, and the pulse surveys will potentially pick that up as well, so that people are aware of Speak Up and speaking up safely, aware of more wellbeing initiatives that we've got going on. The surveys we do tend to be quarterly, and we target hotspot areas or different areas. So next in line for next quarter will be like midwifery, and also the theatres teams. So we can pick up in there whether they've got awareness of like the ambassador roles, for instance, because it's a question we ask specifically in that survey. And yeah, hopefully just a reporting upwards, so more cases potentially.
And I think it is always the thing which it sounds perverse, but the better we are at creating a freedom to speak up culture, the more incidents we have of people speaking up. That's a good thing. If you've got a low number, that it's not culturally a good thing. Any other questions to Sue? So just one from me. How is it working across the ICS, the Freedom to Speak Up Guardian work? Do you coordinate with colleagues across the ICS, and is that working well?
Yes, we do. I'd say it's in its infancy at the moment, and there's no steer as such from the National Guardian's Office as to how ICSs should form themselves for Speak Up. But myself and the Guardians from the local CCG and the other local trusts within our area meet regularly to discuss. We've got a meeting in the new year to start looking at a more formalised policy around how we work as a Freedom Speak Up team, and whether we structure ourselves with like all of the people that are in our system can report to any of the Guardians within our system, but then the Legacy Trust owns the data and the concern. We haven't worked it out yet, but not many ICSs have, I don't think.
I think it's absolutely one of the key things we need to ensure, particularly given the history of parts of the Midlands when it comes to whistleblowing, that we're all on the same page on freedom to speak up and we're all at the same standard. Thank you, Sue. Lovely to see you. If I don't see you before Christmas, have a wonderful Christmas.
Thank you, Chair. Nice to see you. Thank you.
So we then move on to the Foundation Group Strategy Subcommittee Terms of Reference, which I'll take in Glenn's absence. These have been revised in the context of the arrival or welcoming of Worcester Accused as an associate member of the Foundation Group. And they also sort of substantively change some of the job titles, which is a minor point of colleagues, but invite directors of strategy going forwards to the Foundation Group Strategy Subcommittee. So with that sort of background, any questions? Okay, I can't see any digital hands. So if you're not happy to approve, please raise a digital hand. Okay, can't see any raised digital hands, so duly approved, thank you. So then move on to the different subcommittee chairs updates. The first are yours, Glynis. Glynis, over to you.
Thank you, Chair. At our November meeting, just to make board aware, we did spend quite a bit of time focusing on the workforce element of our agenda, given it's one of our biggest challenges at the moment, and there are concerns around vacancy rates and absence. That, just to note, that's compounded by an anticipated shortfall in deanery placements to the trust. So over winter, we've got 10 places left. But we are mitigating that by recruitment to middle grade posts, but it does still remain a significant risk that we just wanted board to be cited on. The other area we looked at and discussed was picked up in this morning's development session. That was about the wellbeing agenda and how we can strengthen our assurance regarding equity of access to that, and also the impacted intervention. So that will come back to us in due course at QUAC. Other area we remain very cited on is the workforce challenges in maternity. Absence rates currently at 10%. However, we did take assurance that one-to-one care has been maintained at 100%, and that there is a positive progress in terms of their recruitment in maternity services. So we can see progress in that area. What we did want to just point out is also that we saw evidence of good progress in evidencing compliance against the Ockenden requirements. So there's a lot of hard work happening in maternity, and we thank the services for that. We took a lot of assurance regarding safeguarding, meeting our statutory duties, and also good assurance regarding that alerts are being managed and monitored against compliance in a very timely manner. And we also took good assurance that corporate risks are being effectively reviewed and managed. The only other area probably just to note was the trust is partially compliant against the accessible information standards. That's quite a big piece of work. There's been a lot of progress made against it. And we were very pleased with the work that's taken place with a focus on interpreting services, with a good programme of improvement work that was brought to committee that we were cited on. I think that's probably the main points from our meeting.
Thank you, Glynis. Any questions or perspectives, Glynis? Okay, thank you. So we'll move on then to the Audit Committee, the 28th of September. Julie, over to you.
28th September minutes, I think, and the report from last week, Chair. The report from last week I'll take as read. I just wanted to draw to the attention of the board two areas that have previously been raised by the Audit Committee. I think you can see that the report demonstrates good governance and control, but the two areas that we took a lot of time to scrutinise last week were around the closure of pharmacy outpatient aseptics unit. And as you can see, that we heard about the significant non-financial benefits and also the avoidance of capital associated with this change and the change in leadership. But we did hear that the closures were actually expedited because of operational pressures, which meant that they weren't subject to business case consideration. We took assurance from the executive colleagues that were with us that this has now been rectified and is being rolled out, and that the approach taken by the coordination cell now is to adopt a full business case review for all changes and transformation. We also heard about the final EBME internal audit report, which you recall we were concerned about in the previous audit committee. Significant work has gone on there to actually complete all of the internal audit recommendations. There were a couple that were still outstanding, which we received assurance that they are in hand and will be completed. And that was with the help from SWIFT. Thanks very much. I'll take it as read. And any questions?
Thank you, Julie. Any questions to Julie on that audit update? Thank you, Julie. I'll then move on down the pack rather than the agenda. The Foundation Group Strategy Subcommittee report for the 18th of November, which, Julie, is there anything you want to add to it?
No, I think we've talked already about the review and the partnership with the University of Warwick. I think the only thing for me that I'd like to point out is that it was a significant agenda last time, and the report sets out the number of areas where we're working together and the benefits of actually working together as a group.
Great, thank you, Julie. Any questions to Julie on that report? I would just like to put on public record, I am delighted about the strengthening of the partnership with Warwick Medical School, but in no way do I want to underestimate the importance of our strategic relationship and partnership with Coventry University. So we then move on to the Improvement Board paper. Jenny, anything you'd particularly like to pull out here?
Yeah, just to say that, so we're reporting this as the business from the Improvement Board. Ordinarily, Glenn would present this as the chair, so this is a move away from the new way of reporting in from the Improvement Board, so you get the overview of the business that's gone through that, like the other boards and committees. You can see the report pulled out the improvement stories that were shared. I will just reference the point that corresponds with the point that was made by Julie about the fact that there is now a process in place for review points for all business cases and also for improvement programmes that deliver and complete, and that's part of the benefits realisation process, and then that will come forward through to board in terms of improvement stories and benefits profile. And I would also just pull out the fact that we specifically heard about a new initiative around a poverty proofing project, which I think is a really exciting initiative and supports our work around health inequalities. Although we are, as a board, looking at the timescales for delivery on that, bearing in mind some of that it was focused within the maternity department. So those would be the points I'd pull out.
Thank you very much, Jenny. Any questions from colleagues on the Improvement Board paper? Yes, I think we're then on to any other business, colleagues. Any other business, please raise your digital hand. I've got one. I'd like to go back to what I said at the start and David touched on, which was, and if you can come on screen, please, Stephen. It's been an enormous pleasure to have you as our crew over the last few years. We were really pleased when we appointed you, and you've had a great impact. In many respects, you have been an exemplary member of the Foundation Group, working with your other crew colleagues, both in the region and the Foundation Group. We were all immensely sad to be losing you, but really pleased for you. It's a wonderful career opportunity. And we wish you all the very best. You go with much affection, and we will miss you. But there is always a home back in the Foundation Group. If ever the journey across to that eastern corner of the Midlands becomes too wearisome, just come back to your natural home. But Stephen, thank you on behalf of all of the board, all of your colleagues and the citizens that you've helped to serve. Board, a round of applause for Stephen. So we haven't had any formal questions from members of the public, but if any member of the public wants to ask a question, could you put up a digital hand now, please? David?
Thank you, Chair. It's not so much a question, but more echoing the feelings of the Patients Forum towards Stephen on the next chapter in the book of life for Stephen. And certainly we've done an awful lot together, and a big thank you therefore from the Patients Forum, and all the best for the future. But just a message, Chair, if we may, on behalf of the Patients Forum, a huge thank you to all the staff at the George Eliot Hospital for their dedication over the last 12 months. And we wish them all a very, very Merry Christmas or festive season, and look forward to being with them in 2022. Thank you, Chair.
Thank you, David, and thank you to you and all members of the Patient Forum, the League of Friends, all those volunteers that we have in the Trust, as well as our fantastic full-time colleagues and our partners. Can I wish you all a very Merry Christmas. Please take care. Please get your booster jab as soon as you're able to. Continue to be safe by wearing a mask, being sensible about social distancing, wash your hands more often than otherwise you would, but enjoy the festivities of Christmas, and we look forward to seeing you in the new year. For my board colleagues, we'll take a 12-minute break. We'll get back together again at 3:30 for the confidential board. Thank you very much.
Merry Christmas, everyone.
And to you.